Okay. 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 Okay, so let's continue with reviewing this self-assessment from AIMBOS. Um, well, next question is a 33-year-old man came with severe knee pain, swelling since waking this morning. He went to a friend's birthday. So you know what happened in a friend's birthday. You drink a lot, you eat a lot. This is something important. He had a GA bleeding from a gastric ulcer. So you are not thinking to give him an NSAIDs. Show erythema and edema on the right knee. Show yellow negative birefringent crystal. So you know this is from you know um, gout when you see this. The treatment for this patient condition is initiated. The next day, the patient developed diarrhea and nausea, the symptoms most likely caused by the drug with which of the following mechanism of action. So now you know that there's a patient that have an acute gouty arthritis. Um, you can see for all the information they gave you, and for that reason, you categorize this as an acute um, gout arthritis, so you need to use the acute gout drugs that are NSAIDs or um, colchicine, right? So these are the both that you use for acute gout attack. They lead to inhibit the inflammation from the urate crystals. That's not the same that the drugs that you use in the case of not the acute, right? The chronic. Mm. So here you have it. Purines, hypoxanthine, xanthine, uric acid, xanthine oxidase. So here you use inhibitors of xanthine oxidase that are halopurinol. Um, and also febuxostat, right? Um, and then, well, to inhibit the reabsorption, you can use probenecid, and that's it. Pegloticase, uh, it's to convert the uric acid to allantoin, that it's easy to excrete in urine. But this is the drugs not for the acute. And for the acute, you used colchicine, which is mechanism of action. It binds and stabilizes tubulin to inhibit microtubule polymerization. This impairs neutrophil chemotaxis and degranulation. Um, and when the adverse effects could be myelosuppression and nephrotoxicity. Okay, so this is the answer. Actually, was like pretty obvious. The most common mistake people made is this one, that inhibit the active metabolism, thinking about what you use to the chronic treatment, but in this case you need to think to the acute treatment, and you cannot use NSAIDs because this patient have this problem with the gastric ulcers, but you can find the same stuff. This is actually the same stuff. There's nothing more here, but we can review this. For example, this is in the biochemistry section, and here we talk about the cytoskeletal elements. Um, well, here it is. Microtubule is a cylindrical outer structure composed of helical array of polymerized heterodimers of alpha and beta tubulin. Each dimer has two GTP bound incorporated into flagella, cilia, and mitotic spindles, also involved in exoplasmic transport in neurons. Molecular motor proteins transport cellular cargo toward opposite ends of microtubule. Dynein, retrograde, anterograde, kinesin. This is important. Clostridium, tetani, herpes simplex virus, poliovirus, and rabies virus use the name for retrograde transport to the neuronal cell body. Drugs that act on microtubules, well, they use microtubules, get constructor very terrible, mebendazole, Rhizofulvine, colchicine, bean alkaloids, that's anti-cancer, taxanes, anti-cancers, negative and near nucleus, positive endpoint to verify. Ready, retrograding to attack. It's part of the cytoskeletal elements, right? Microfilaments, acting microbially, intermediate, maintain cell structure, and microtubules are for movement and self-division. Okay. This is something they ask you. The E-cell disease. Okay. Next question. Question number 14. A 71-year-old man, droplet precautions. He has hemophilus. Medical history is remarkable for permanent bilateral hearing loss. An interpreter in ASL is available to help communicate with the patient. Which of the following is the most appropriate action by the physician to ensure successful communication with the patient? Well, this is a patient that just like needs SAL. This is a question that's actually, it's important to know for you that I'm not, I think everyone can see that I'm not like American and my mother tongue is in English, but in my case here in my country we have our own sign language, and I used to speak our sign language, and it's important for you to know that when you use the sign language, you need to see the face because it's important of the way you express all this stuff. It's a little bit difficult to do that without without showing your face. So and also what is more important here is that you are speaking, so the interpreter needs to see you. Okay. Okay. Wear a face mask with a transparent plastic panel seems to be the most like the best way to treat this, because you will be safe because of the droplet precautions. They allow for the lip reading because some patients also do not speak ASL, and they actually could like read the lips, and also used to we can see the facial expression. Mm, that's it. It was an easy one. A 48 years old man comes to a physician because of 5 months history. Sorry, 5 month history of episodic headaches, dizziness, and blurry vision. He reports generalized itchiness after takes a shower. He has had 3 episodes of epistaxis during this period. Physical examination shows facial redness and splenomegaly. Laboratory studies show an increase in hemoglobin concentration and decreased HEPO concentrations. Which of the following is most likely responsible for this patient condition? This patient has classic symptoms of polycythemia vera, including pruritus, plethora, hyperviscosity syndrome, and splenomegaly. Genetic analysis would most likely show um, B617F mutation in the JAK2 gene. So, well, he has polycythemia vera. You can see because basically he has hemoglobin concentration and decrease in hypoconcentration because the kidney doesn't want more hemoglobin. He's 48 years old. So PV is a chronic myeloproliferative disorder that is associated with the JAK2 proto-oncogene that enables constitutive activation of JAK2 tyrokinase into an oncogene. The gain of function mutation in the JAK2 gene causes increased intracellular signaling, which results in a dysregulation of myeloid cell growth and hypo-independent proliferation in in all the myeloid cell lines. Okay. So well. Um, okay. So here it's polycythemia vera, pathophysiology, JAK2 gene mutation, more proliferation of RBCs, um, that leads to blood hyperviscosity, diagnosis, erythrocytes, um, that leads to more hemoglobin, hematocrit, red cell mass, and less EPO. Sorry, just give me a second. I ran off battery, so I will move and connect this. Okay. Okay. So here in polycythemia vera, you will have neurologic symptoms that was described: dizziness, headaches, arterial thrombosis, plethora, mucosal bleeding, visual changes, hypertension because of the um, hyperviscosity, right? Constitutional symptoms, example, fatigue, insomnia, weight loss, splenomegaly, peptic ulcer, erythromelalgia, aquagenic pruritus, petechia, hepatic vein thrombosis. Okay. Diagnosis: erythrocytosis because of more hemoglobin and red cell mass, less HEPO, genetic analysis, and bone marrow biopsy. Treatment: regular therapeutic phlebotomy plus low dose aspirin. High risk patients, the one that um, use hydroxyurea. Target hematocrit less than 45. Complications: progression to AML and myelofibrosis. But if you're not clear, that's actually my case. To be fair, like hematology is not my, the one that I know the most. It's actually the one that I know the less. um, so well, I need to um review it more. Policy. Sorry. Well, so here, also here in this case is a erythrocyte sedimental rate. You should know that in sickle cell anemia or in polycythemia vera, or heart failure, microcytosis, you will have less. But in most anemias, infections, inflammations, cancer, renal disease, you will have higher erythrocyte sedimentation rate. Also in here, this is important to the giant cell arteritis. Mm, okay. If there's polycythemia plus more EPO, paraneoplastic rise to high hematocrit levels. Eisenmenger syndrome that leads to the shunt right to left. First, it's a left to right shunt. So because of a BSD or ASSD or PDA, then there are more pulmonary blood flow, that pathologic remodeling of vasculature, pulmonary arterial hypertension, RVH occur to compensate that right ventricular hypertension, and the shunt becomes right to left. Yeah, because it's bigger. Right ventricle it's have more pressure than the left, and it can have polycythemia too. There are more able, so there could be polycythemia. In the Budd-Chiari syndrome, Budd-Chiari is hepatic venous outflow tract obstruction, so it cannot go to the IVC due to thrombosis, compression with centrilobular congestion and necrosis, congestive liver disease, hepatomegaly, ascites, varices, abdominal pain, liver failure, absent of GBD associated with hypercoagulated state. Makes sense, right? Here it is. Myeloproliferative neoplasm, malignant hepatopoietic neoplasm with varying impact on the white blood cell and myeloid cell lines. Polycythemia vera, primary polycythemia, disorder of RBCs, usually due to acquired JAK2 mutation. Might present as an intense itching after shower, that the aquagenic pruritus. Rare but classic symptoms are erythromelalgia, severe burning pain, and red blue decoloration due to episodic blood clots in the vessels of the extremities, associated with hyperviscosity and thrombosis. Um, less EPO versus secondary polycythemia, which present with endogenous or artificially um, rising of HEPO. Treatment, phlebotomy, hydroxyurea, rusotinib, or JAK1/2 inhibitor. That looks super cool. Essential thrombocythemia characterized by massive proliferation of megakaryocytes and platelets. Symptoms include bleeding and thrombosis. Blood smears show markedly increased number of platelets, which might be large or otherwise abnormally formed. Erythromelalgia may occur. And myelofibrosis, a typical megakaryocyte hyperplasia, due to can lead to a rise in the TGF-B secretion um, that leads to more fibroblast activity, obliteration of bone marrow with fibrosis associated with splenomegaly and teardrop RBCs. Here are the teardrop. Bone marrow cries because it fibrous and it's dry tap. Okay. Mm, mm, mm. Okay. So let's see what are the other answers. Exposure to a carcinogen. Um, Mutation of a tumor suppressor gene, loss of function mutation in tumor suppressor genes like P53 are a hallmark of many malignancy, but not here because it's not suppressor, it's a proto-oncogene. So that's cool. Cellular immortality is a hallmark of carcinogenesis that can be overrating of telomerase to substance sustain telomerase length and infinitive replicative potential. Okay.